Hi, and welcome to the May 29th, 2013 St Vincent's Hospital Plastic Surgery Journal Club. My name's Damien Marucci, and this is Rebecca Dunlop, who's a visiting fellow from the United Kingdom. So Rebecca, this evening as usual we did the 4 papers. So what was the first paper we did?
That's right, Damien. So the first paper we did was talking about the use of platelet-rich fibrin in wound healing.
Okay, so what was the gist of this paper? What did they do?
So this group used post-surgical patients who'd had a Dupuytren's fasciectomy using the McCash open palm technique, and in one group, the trial group, they applied some platelet-rich fibrin to the wound immediately post-operatively, and then they had a control group, and they compared outcomes such as the time to wound healing, the number of dressings needed, the pain that the patients experienced, and also the wound exudate and bleeding.
Yeah, and the platelet-rich and leukocyte-rich fibrin they used, which is very interesting. It was just ordinary blood which they'd drawn off at the time of surgery.
That's right.
Then they just centrifuged down 4 9mm vials without any coagulant in it. They then just got a solid clot. They cut off the one segment of it that they didn't want. Yep. And then the rest of it, they just used that as a paste, which is a semi-solid sort of thing, and they just use it as a dressing.
That's right. So they squeezed it between 2 gauzes and applied it directly to the wound.
Yeah.
Then both groups had the same layered dressings applied on top of that.
And then they had a community nurse looking at the wound every couple of days, and also one of the assessors also looking at the wound. And so the main endpoints were, they looked at things like pain and exudate and bleeding, but the main endpoint was time to wound healing or reepithelialization. And they found that there was a statistically significant improvement of 5 days in the treatment arm versus the non-treatment arm.
That's correct. So they defined wound healing as not requiring any dressings anymore, and that was as decided by the community nurse.
And this was a pretty cool sort of human model for wound healing. It's a surgically created sterile wound. You don't have any of the confounding factors of bacterial colonisation or the like. And generally speaking, I thought people thought it was a pretty good paper. It
was very well received, and I think it's the applications for platelet-rich plasma and platelet-rich fibrin are going to become wider and wider, and we're already seeing in our practice that we're actually being asked for it by our patients.
Yeah. Okay, so that was a pretty good paper. And then the second paper we looked at was at the rectus sheath. So this was looking at patients who'd undergone rectus sheath plication as part of an abdominoplasty. It was from the Czech Republic, published in a recent PRS. And they were using post-operative ultrasound to look at the distance between the medial edge of the rectus abdominis muscles, comparing that with a cohort of patients who hadn't undergone the surgery, and looked at the distance between their recti to see whether or not using resorbable sutures as opposed to non-absorbable sutures made a difference in terms of the stability of the rectus sheath plication.
That's right. So this group used OPDS, and the reason that they did the study was that a previous group who had tried to compare the efficacy or long-term efficacy of an absorbable suture had used Vicryl, and their methodology had been flawed. So this group was trying to correct that.
Yes. But speaking of flawed methodology, one of the concerns that was brought up was the fact that they were only evaluating the distance between the recti post-operatively. So it wasn't like if they'd done a pre-operative assessment to look at what the distance was, and then the patient had the surgery, and then maybe do another measurement at, say, 1 week, and then do another measurement at, say, 1 year, to show that using a resorbable suture, it didn't sort of spring apart or anything like that. I thought that would have been a good thing. And also you had an important point about the validation.
Yeah, I mean, there were major weaknesses, unfortunately, in this trial, which is a real shame, because the audience would have liked it to have been conclusive and so that they could have applied it to their own clinical practice. But you're right, they did no preoperative measurements, so they're really just supposing that these women had rectus diastasis to start with, and there's no evidence that they did. They also were very scanty on the surgical technique details, so didn't say whether the suture was interrupted or continuous, the spacing between the different stitches, or indeed how they assessed the laxity of the rectus sheath, how much they brought it in together. And then the outcome measure, which was an ultrasound guided distance between the two rectus muscles, this, you're right, it's not validated. They only used one sonographer at one point in time to measure it. So yeah very disappointed in that study.
I mean, look, I've got to admit, I use PDS for my plication, but it would be nice to have it answered more definitively. Okay, the next paper we looked at was, this was looking at outcomes of pyrolytic carbon arthroplasty for PIP joints and looking at 44-month follow-up. This is from the unit in Ann Arbor, Michigan. So what was the idea behind this paper?
So these Ascension pyrocarbon PIP replacements are relatively new on the market. There have been quite a few studies of the short-term outcome and just 2 intermediate-term studies so far. And this group was hoping to add to our knowledge of how these implants perform in the intermediate term. So they had a group of 13 consecutive candidates, and they measured immediate complications from surgery such as infections, squeaking, loosening, pain, and they also had some functional measurements such as range of motion, and they used the Michigan Hand Outcome Questionnaire as well, in addition to grip and pinch strength. Yeah.
And their results were surprising in the sense that the patient-reported outcome measures were all very positive. The patient liked it, they'd recommend it to their friends, they found decreased pain and all that kind of stuff. But in terms of their complication rate, it was actually quite high. There was a 64% incidence of radiographic evidence of loosening and a 33% incidence of overall complications.
I think it was even higher than that.
Right,
something
sorry.
like 42.9, 43% early complications, which is enormously high.
Yes.
And one of the comments from the floor was that really this needed to be compared to the current gold standard, which is the silicone arthroplasty or arthrodesis. And what are we doing a procedure with such a high complication rate?
But it is good that the patients felt better in spite of the high complication rate.
Yeah.
So anyway, that was a very interesting paper.
Very interesting.
Okay, the final paper was probably the most interesting and certainly provoked the most discussion. This was following on from a paper we did last month in Journal Club looking at the use of acellular dermal matrix in immediate expander implant-based breast reconstruction. This paper again was from the Memorial Sloan Kettering unit in New York. And it was a unilateral preoperative chest wall irradiation in bilateral tissue expander breast reconstruction with acellular dermal matrix, a prospective outcomes analysis. So this paper was looking at 5 years of data which was prospectively collected but retrospectively analysed of patients who had previously had a lumpectomy and radiotherapy and then at some point later were presenting for not only a mastectomy on the irradiated side but actually a bilateral mastectomy with immediate tissue expander implant-based reconstruction. So both sides were treated with acellular dermal matrix, but obviously one side was the ADM was going into an irradiated bed, whereas the other side it wasn't. And so each patient acted as their own control. So it was in a sense a case control study. And they were looking at the complication profile of the ADM on the irradiated side compared to the non-irradiated side. And what was sort of the summary of the results?
Yeah, so you'd imagine that you'd have a much higher instance of complications on the irradiated side, but they found that there wasn't, which really raised the possibility that the acellular dermal matrix was great at dampening down those radiotherapy-induced complications, which is really good news.
Yeah, there was an incidence of infection, a higher incidence of infection, I believe, in the irradiate group,
yeah.
but it didn't reach statistical significance. So, I mean, one of the issues is that maybe if they had have had more than the 23 patients enrolled in the study, that they may have found a statistically significant increase in infectious complications. But what a lot of the discussion during the Journal Club went around was, does this mean the end of having to do a latissimus dorsi flap at the time of immediate breast recon in an irradiated field? Using ADM, it's not cheap. ADM costs around $4,000 to $5,000 per breast. However, comparing that cost with the expense of the theatre time and the recovery time of a latissimus dorsi, one would imagine it's going to be pretty close.
I think for patients, it's particularly pertinent as the age of incidence of breast cancer gets younger and these women are more active and they're much less inclined to lose their LD. So I think this could be very significant. And
I find that harvesting the LD muscle not only takes time, but it does involve some morbidity, not just scars on the back, but I tend to leave my drains in for 3 weeks post-operatively, which is Hammond wrote a paper about how he does it, so he leaves them in for 3 weeks minimum, so that's what I do. And even still, you still have an incidence of seroma, which is really annoying. You've got to see the patient every couple of weeks and drain the seroma and the like. Whereas this gives us potentially an opportunity to avoid doing that, and you haven't burnt any bridges. If it all fails,
you can
still do your LD down the track.
Yeah, absolutely. I mean, a mastectomy is a mutilating operation for a woman in any sense, and so if you can do anything you can to reduce the extra scarring and morbidity, then it's good news.
Okay. Well, Rebecca, you did a fantastic job. That was an amazing journal club.
Thank you, Damien.
And so for those of you who were there, I hope you enjoyed it. And for those who are watching now, thank you for listening. Okay, bye.